This is Focus on Your Health. It's brought to you by Kingman Regional Medical Center in historic Kingman, Arizona. I am TG LaFredo, and this week I'm coming to you from KRMC's Wallapai Mountain campus. My guest, back again, his triumphant return, it's Dr. Eric Feldman. He is a doctor of pharmacy at KRMC. Hey, Dr. Feldman, welcome back.
Thank you. It's good to be back.
It's good to have you back. Let's see, this week on the program, we are talking about antimicrobial stewardship. And the reason that we're talking about this is, well, for one, it's interesting. But a couple of months ago, you and I got together and we were talking about antibiotics. I wanted to ask you about stewardship, and I realized, or maybe we realized, holy cow, this is a big topic. It needs a conversation in its own right. So we're going to dive in on antimicrobial stewardship, what that is, what it means for medical institutions, and what it means for patients. First, we should probably lay the groundwork and get some 101 level definitions. Is that okay?
Absolutely.
All right. What are antibiotics?
So, of course, antibiotics are medications that are used to eliminate bacteria. We also use antibiotics for a few other things in certain situations, but primarily it will be used to treat infections. You have your urinary tract infections, pneumonia, skin infections, very common things. But of course, when we talk about antimicrobial stewardship, this encompasses many different types of microbes, not just bacteria, where we also have viruses as well as fungi too.
Yes, this is going to become relevant to this conversation.
Absolutely.
Okay. How do antibiotics work?
It's a tricky question. There's lots of different classes of antibiotics, and over many, many, many years, we have developed new ones that actually work in different ways. Most common ones that you see will typically help to eliminate bacteria in a way that bacteria are like fortresses. They have walls. So we use antibiotics that will penetrate, break their walls, and essentially get rid of them. There's also other antibiotics that work on DNA and RNA and break down certain strands specifically that bacteria can make. Now, one of the complications with antibiotics that we'll touch on a little bit more during this talk is there hasn't been a lot of development in new antibiotics that work in brand new ways.
We know that antibiotics are important, so I'm not going to ask, are they important? But what I will ask is, if antibiotics don't do the job, what would happen? So, for example, I have something that would require an antibiotic, but say I don't have access to it. What might happen?
Absolutely. So we, of course, have immune systems. So ideally, antibiotics help aid our immune system to get rid of infections. Our immune system will also be our backup there. Now, if for someone who might not have an antibiotic, they could develop into a more severe infection, of course, require hospitalization and things like that. So that's why, ideally, if you can get the patient the right antibiotic and treat the most likely pathogen or bacteria, would it be that's causing that infection, then you can help prevent hospitalizations, which is a big thing.
And if I just didn't have access to that and my immune system didn't do the job, we're talking, I guess it would depend on which particular bacteria we're looking at. It
depends. Some, of course, are going to be more virulent in the sense that, they can be more dangerous. Of course, you can have an increased risk of mortality. And one of the things that we'll touch on in this discussion is that in certain places, especially in different parts of the world, some people don't have access to the antibiotics that we have in the U.S. And because of that, unfortunately, some people face the consequences of that.
Sure. What is antibiotic resistance?
Bacteria are living organisms. And what happens is antibiotics will kill off those organisms, but sometimes you might have a residual bit of those organisms that actually can survive the antibiotic you give them. Now, when you eliminate the bacteria that are susceptible and able to be killed by the antibiotic you give them, now you leave the ones that can actually tolerate that antibiotic and fight it off and become resistant. So essentially, in medical terms, we call it selective pressure. You're selecting for a group of bacteria that are going to be more resistant and they're going to be tougher to kill. So now sometimes you really have to find out what is that bacteria that might be causing that infection. we do have technology where we can actually grow them on plates and use PCR technology and other means to help identify these bacteria, as well as find out what antibiotics work best against them.
This is the crash course in antibiotics, and we've at least set the foundation to look at antimicrobial stewardship. So what is that?
It began in the 2010s, where you had a lot of different organizations. You had the Center of Medicare and Medicaid, the CDC, as well as the Society for Healthcare Epidemiology in America, known as SHEA, and the Joint Commission, where really a lot of these different organizations came together and they wanted to implement a way of surveying, collecting data, and making sure that the antimicrobials that we were using in our patients and in different institutions are, one, the most optimized, the most effective, but also the safest. We want to make sure we reduce the risk of adverse reactions, side effects, things like that. Once the groundwork of an antimicrobial stewardship program was underway, that is when the Center of Medicare and Medicaid in the United States actually rolled out that it would be a requirement starting in 2019, and the deadline to implement that in our hospitals was going to be in March 2020.
March 2020, you say? Let me adjust my tinfoil hat. Go ahead.
It was an interesting time. I don't know if that date was picked specifically, but it was a good time for implementation, as because of the pandemic at the time, this is a time where really when you could have the partnership of a infectious disease physician as well as an infectious disease pharmacist work together to really collect all the evidence and data that we had at the time to combat COVID and the pandemic. And that's where we really saw the benefits of these stewardship programs. One thing that I want to preface about antimicrobial stewardship is that I am not an infectious disease pharmacist, as typically that is a specialist position, requires extra training. But infectious disease and stewardship is something that I am very passionate about, and I spend a lot of time educating myself and researching. Now, given stewardship is not limited only to an infectious disease physician and pharmacist, where in terms anyone can be a steward, and that's what a lot of these programs really try to put out there to healthcare workers and our community.
It sounds like the conversation on antimicrobial stewardship began in earnest in the mid-2010s or thereabout, late 2010s. Was there some precipitating event that brought that to the forefront?
Absolutely. Back in the past, one of the big scary bugs that people really heard about was MRSA, or MRSA, methicillin-resistant Staph aureus. And that showed a time where you could have bacteria that are very difficult to treat and can be quite deadly. As time progresses, especially in other parts of the world, we start to see bacteria that already are innately very resistant to a lot of our common bacteria. One of the most popular ones is Pseudomonas. There's also Acinetobacter. Those are usually your two big bad guys in the room, where they're difficult to treat. And as you treat them, there are situations where they can become resistant to the antibiotic you're giving them in the middle of the course. Typically, though, you don't see these bacteria in the community. This is typically something that's more in healthcare settings, but even then, this is something that really spurred a lot of these advancements in stewardship. Especially, I got a fun fact for you, it's estimated that by 2030, close to 2/3 of all the antibiotics prescribed in the United States are actually in the food supply. So, for example, cattle, livestock, they actually receive 2/3 of all the antibiotics prescribed in the US. So another factor when we talk about stewardship is not just in humans, but also in our food chain as well.
And so if we are meat eaters and that gets into our meat supply and then does a round trip, comes back through us, what are the implications?
So potentially there is a lot of research to try to see if that does increase the risk of antimicrobial resistance in ourselves when we eat those foods. That's why when you go to your grocery stores, you'll see a lot of products that say, no hormones added, and sometimes you'll see no antibiotics added as well.
Okay, this is getting more complicated as we go. Returning for a moment to MRSA, Does this qualify as what we've heard of the dreaded superbugs?
It definitely belongs in that class of superbugs. Now, treating MRSA, we have many agents that can get rid of MRSA, but MRSA is one of those bacteria that we can commonly see in healthcare practice, but there are other bacteria that are more rare and more niche that actually do require a lot of evidence and a lot of training to treat.
I know medical institutions everywhere, all across the country, are working to reduce what are called hospital-acquired infections. This is just what we're talking about. Is that right?
Of course. So hospital-acquired infections are something that stewardship programs especially try to reduce. Two big ones really are healthcare-acquired central line infections. What does that mean? If you have an IV line that goes into your body, there is a risk of developing certain infections. So we take a lot of measures to make sure that we create a safe and sterile process in doing that, especially with urinary tract infections. If someone requires a catheter sometimes, there's a lot of effort just the same way to make sure that we reduce the risk of infections that way.
What are the goals of antimicrobial stewardship?
There's about 5 goals. One of them is to work with healthcare practitioners to make sure that we're giving the right drug, the right dose, especially route. We can give antimicrobials in a lot of different routes, such as we can give it by mouth, we can give it by IV. There's many different ways. But to make sure that we give it the right way sometimes can be the most effective, especially it can be a cost measure. It'll save our patients money, it'll save our institutions money, making sure that the duration of treating that infection is appropriate, as well as making sure that, for example, in clinical practice, if I'm in the hospital, making sure that if we don't know what bacteria is affecting our patient, we might start with an agent that actually can target a lot of agents, but once we know what we're battling, we can really de-escalate and narrow down our treatment. Another step in antimicrobial programs is to prevent antimicrobial overuse, reduce antibiotic-related adverse effects such as developing C. diff, minimize resistance, as we talked about, and to reduce healthcare-associated cost.
Well, at the risk of asking an obvious question, how does antimicrobial stewardship improve patient outcomes?
Antimicrobial stewardship can improve patient outcomes by making sure that if we have patients in the hospital, for example, and once they're stable and ready to go, we can make sure that we give them the best antibiotics, such as an oral option. That way, a patient might not have to stay in the hospital to receive IV antibiotics. They can go home. Another way by doing that, as I mentioned, is reducing healthcare cost. Giving capsule or pill is much cheaper than staying in a hospital and getting IV. So that's another option that we can try to benefit our patients. And of course, minimizing resistance is going to be a key role. One of the things that stuck around with me that I learned from our infectious disease physician is that really when you look at bacteria, it is a biome, almost like a city, especially in our human bodies and our guts. We have a lot of bacteria and they live in harmony, but also antimicrobials really impact our community in the same way. So one of the ways that we try to minimize resistance is we actually track resistance rates yearly within every hospital and within every community. That's something that's set forth by these programs. So we can see where are the resistance rates rising as well as where are they declining.
I have a note here to ask you about how those rates get tracked. Can you give a little insight on that?
Absolutely. So what we use is an antibiogram. So what we look at is how many bacteria have we captured from patients. So were we able to collect a sputum sample, maybe a urine sample, and actually grew a bacteria. So we collect how many of those strains of bacteria, and then what we monitor is, do we have strains that are really easy to treat? And what are the percent of those strains that are actually going to become more resistant, a little bit more difficult? And by using that, we can actually find out on a year-to-year basis, we can see where the trends are.
If you're just joining us, this is Focus on Your Health. I'm TG LaFredo, and this week on the program, my guest is Dr. Eric Feldman. He is a doctor of pharmacy here at KRMC. Dr. Feldman, in the course of our interview, a couple of different times you have made the point that anyone can be a steward. I think we've touched on the ways in which pharmacists, doctors, nurses, all those medical professionals play a role. Can the lay public play a role as well?
Absolutely. being a steward really can encompass the fact that not all infections are caused by bacteria. One popular thing that you might see nowadays, especially when you go to urgent care clinics, is that, for example, if you catch the common cold or the flu, that is a viral infection caused by a virus. Antibiotics do not affect viruses. So in cases like that, that is where anyone can really be a steward to say, oh, I don't think this patient might need antibiotics because they have a case of a viral infection that might go away after a few days, and trying to explain that to a patient and where they will understand that and actually say, oh, okay, so, if I do a lot of supportive care, stay hydrated, really try to take care of myself, this will resolve itself without the need for antibiotics.
And this can be a tough sell, right?
Absolutely.
Because the patient is not feeling well or the kid is home from school and we're not exactly sure what he has. And so if it's a virus, supportive care is the answer because antibiotics will not address the problem, right? But if we don't know exactly what it is, I know many doctors face pressure from patients, from parents, and they say, well, just give us this prescription. Although if it's a prescription and it's targeting something that's not there, then it can affect our overall ability to actually use that medicine. Is that correct?
100%, absolutely. Especially, as a provider, you want to make sure that you give something to your patient that will benefit them. And, working in healthcare, we always try to make sure that we weigh the benefits and the risks. Now, for example, given with providers, they have the education and the knowledge where they can try to differentiate what they believe is something that's bacterial versus something that's viral. And luckily, we have agents and medications that can work against viruses as well. So it's good to try to make that delineation and make sure that you give your patient the best option that you clinically believe will fit your diagnosis at that time.
I can say that I've spoken with medical providers all around, not just here at KRMC, but different places in the country. And it's something I've heard again and again from them about receiving pressure from patients to just give me a prescription so we can try to knock this thing out. Even maybe they don't really understand about viruses versus antibiotics. And even certain people who should really know better have had to wrestle with those sorts of problems. Have you ever been asked to provide guidance or to kind of steer someone in the right direction about this issue?
I personally haven't, but it is a difficult battle to face. But especially with being a steward, one of the important measures is education. And you can't win every battle, but sometimes if you can, it's important to educate your patients and, again, weigh the benefits and the risks of prescribing. One of the most important lessons that I learned that pertains to stewardship was during my residency year when I was working on my infectious disease rotation, and I was with our infectious disease physician, Dr. Kahn, and our infectious disease pharmacist, Dr. Dietrich. And one of the things that Dr. Kahn made sure that I understand was the choices that we make, especially when prescribing antimicrobials, not only affects our patients, but ourselves, our community. And over time, those choices have to really be weighed with the risk and benefit, because as antimicrobial resistance increases in our communities and globally, this might not be a consequence that we face in our lifetime, but it can be a consequence for the next generations. That is why stewardship is a very important component of a healthcare industry and facility.
So, Dr. Feldman, what is our current state of stewardship?
So currently with stewardship, what we see that is mandated in a lot of our hospitals, institutions, as I mentioned previously, is that typically you have an infectious disease physician who is guiding the program, as well as an infectious disease pharmacist, and they work hand in hand. Now, currently, we have a lot of special antibiotics, especially when we are talking about very resistant bacteria. And the benefit of having two specialists as an infectious disease physician and pharmacist is that they can really use a lot of data and evidence and clinical thinking, where when you're treating very, very complicated and specific infections, they know when to bring out big gun antibiotics. The negatives to some of those antibiotics is that because they are newer treatments, they can be quite costly, although they are very effective. So that's why stewardship is important, and to make sure that you have designated chairs of an antimicrobial stewardship program. That way they know when do we use these specific agents. Now, one of the things that are important to keep in mind with stewardship is that bacteria are always emerging and becoming resistant in our communities. And this is not just an issue in our Kingman community or in Arizona. This is a US issue. It is a global issue where we're seeing, and unfortunately, some countries actually face much higher rates of resistance in their bacteria compared to us in the US. And what makes it more difficult is that some countries don't have the means and the funds to get the antibiotics that we have in the US.
That's where we are right now with stewardship. In the moment that we have left, I'd like to ask you to take a look to the future, if you can.
Of course.
What's coming for antimicrobial stewardship?
So for stewardship right now is to make sure that we try to create and implement new antibiotics and antimicrobials, because essentially they're our arsenal. There's the Infectious Disease Society of America, known as IDSA, and a lot of different programs in the US are actually trying to pass a new act in Congress called the Pasture Act. The goal of this is that developing medications, especially antimicrobials, is very risky. It is an expensive process, and it's not very profitable for these companies, of course, and unfortunately. The point of the Pasture Act is to help incentivize these manufacturers to try to research and create more of these antimicrobials. That way we have more options, and that way we can keep up with the rates of resistance and keep coming out with more effective and safe strategies to combat infections.
We've been talking about antimicrobial stewardship. Dr. Feldman, give us some takeaways.
The takeaways of antimicrobial stewardship is that this is a big program that has been implemented in the US and all around the world. It's a lot going on behind the scenes that a lot of people don't know about. Antimicrobial stewardship, especially antimicrobial infections, affect our communities as well as everyone involved in healthcare settings and community settings. So one of the things that are important is for us as healthcare providers to stay up to date with literature, use the most effective and narrow agents and safest for our patients, but also for our patients to make sure to listen to the guidance from your providers, your pharmacists, and other healthcare staff, and sometimes just know that antibiotics are not always the answer.
That is Dr. Eric Feldman. He is a doctor of pharmacy at KRMC, and I have on good authority that he came in on his day off to talk with us about antimicrobial stewardship. So, Dr. Feldman, I would like to thank you, and on behalf of the community, I would like to thank you for your time today.
It is my pleasure. Thank you so much. It's good to be back.
That is Focus on Your Health. I'm TG LaFredo, and thank you for listening. Stay healthy, and we'll catch you next time.